You better change your name, but welcome, Docs.
Thank you.
You better change your name.
I can't change my name. My parents will be very upset with you.
Your parents will be upset. Oh, let's change your name. Okay? Right. You're welcome. Right. I'm out of breath for various reasons. I won't share those now. But last week I had lots of feedback. Okay, lots of feedback, and many people were glad we're able to bust certain myths. So I'll kick off with that very quickly. Right? We said that you cannot catch epilepsy, child or otherwise, from anybody. Am I right, Dr. Dakwa?
Yes, please.
Yeah?
Yeah.
You cannot.
You cannot catch
Couldn't,
it.
didn't.
No.
Shan't. Right? So where is this thing from? Is it still to do with the spirits and up there, or what?
So there are advancements in science that help us understand these mechanisms better.
Mm-hmm.
I think from last week's discussion, we concluded on the fact that sometimes, depending on how a person's brain architecture or chemical structure is formed,
Mm-hmm.
you can have a tendency or propensity to have these bursts of electrical activity going on.
Okay.
So it's not necessarily a spiritual, at least from the medical standpoint.
Okay.
Yes.
All right. Medical standpoint is basically primarily where we do this program from, though we've been looking at this from various perspectives because there are different things. Last week, Prosper from Dakuman brought in the fact that they say this and that and that. That one too was overruled by my Supreme Court in the studio here. Is it true that this and that and that and that? So there are lots of things, myths about epilepsy. All right, we zoomed into childhood epilepsy. But one of the things I know working in mental health is that many people literally insist and are almost emphatic that it is a mental disorder. And sometimes people are, moved straight to the psychiatric hospital instead of to see a neurologist. Let me start with you. I won't even mention your name again. But Dr. Hannah Sharon. Aha. Is it neurological, and why the association with mental illness?
Okay. Epilepsy is definitely a neurological disorder.
Okay.
Which means that it primarily comes from the brain.
Okay.
It's a condition that affects the brain, like we said.
Mm-hmm.
And because of the unusual electrical activity that's going on in the brain,
Mm-hmm.
you have the clinical manifestation or the symptoms of what we see of someone shaking or someone being stiff.
Okay.
And that is what epilepsy is.
Right.
We know that in some instances, epilepsy can be associated with other conditions.
Mm-hmm.
It does not mean necessarily that it is a psychiatric disorder,
Right.
but epilepsy can also be associated with things like depression, anxiety.
Mm-hmm.
In children, it can be associated with learning difficulties or cognitive impairments.
Right.
It could be associated with things like attention deficit activity disorder or even autism.
Mm-hmm.
All these are associations. And
Associations.
associations are not the same as causality.
Okay. Right. So if you've heard of people rushing somebody to the psychiatric hospital or to a psychiatric facility, we are essentially primarily and emphatically talking about a disorder of the brain, a neurological disorder, right? So let's get it straight. Let's not get it twisted. If you have any questions, concerns, confessions, testimonies, WhatsApp is 055 11 11 997. We're live on Facebook, X, and of course YouTube. This is Ultimate Health on Joy 99.7 FM with me, Nortey.
Joy 99.7 FM.
By nature. Okay, so we're going into more of the details. We learned about the types. We learned about the general seizure. We learned about the partial seizure. But we also learned that when it comes to seizures or epilepsy, many of them have their genesis or antecedents in childhood.
Mm-hmm.
So it's a serious childhood problem.
It is.
Right?
Yes.
We were clear on that last week.
Yes, we were.
So if you have any of the things we've talked about, you start noticing any of the things we talked about, then have your child checked.
Yes.
Okay. One of the things I asked last week, Dr. Dakwa, is that we're not, do we routinely screen for epilepsy in children?
We don't routinely screen.
Okay. Is it required? Would it be helpful?
No.
Okay.
No. The reason is that last week I mentioned a certain test called the EEG.
Right.
You may have a healthy individual who will do an EEG And then you might find some things on the EEG, you might think it's epileptiform, but it is not.
Okay.
So we usually base on the person's first presentation,
Okay.
and then we can take it from there.
Okay. Right. And we're talking about unprovoked electrical activity in the brain. As soon as we can identify the provocation, then it does not fit the criteria. Am I right? Or
So it's almost 100% right, but the other
So,
thing too is that
yeah,
there are
very
some things
76.
called reflex
okay.
seizures. So
Okay.
let's say someone is exposed to certain frequencies of light,
Okay.
they may have a seizure activity.
Right.
So even though it's unprovoked, we call them reflex seizures.
Okay.
Yes, and they also fit under epilepsy.
Okay. In my line of work, I come across various manifestations of this. I remember once a lawyer's son, but she'd gone to the US and they said it was a pseudo seizure, not exactly a seizure. And she was emphatic, adamant on this, that any seizure, pseudo seizure. What in heaven's name is that?
Okay, so the new term is called functional dissociative seizures.
Okay.
So these are occurrences that look like seizure activities. You might see a certain pattern in a normal a patient with epilepsy, but with the pseudo seizures, the pattern might be different.
Okay.
Sometimes you see things like hip thrusting. You see that the movements will not be the same on each side of the arms.
Okay.
And those are the things that we can use to tell that this may not be an actual seizure.
All right.
Having said that, there are some people who can have epilepsy, and then at certain instances may have some of these pseudo seizures.
Okay.
And in that case, we have the appropriate channels to
Okay.
send them.
So there's actually some activity, right?
Yes.
But you would not classify it as a full-blown seizure or a proper seizure, so to speak.
Yes.
Right. Now, because of the stigma and the related discrimination, right, that is birthed from some of these misconceptions and so on and so forth, when people hear things like this, they hold on to it, that any seizure, right? Should they be doing that? Should they still get some form of management and treatment? Because especially with kids, let me ask you.
Okay, so even though when we use the term pseudo seizure, then it makes it seem like it's not a real medical condition. But it is.
It's there.
It is.
Okay.
So functional dissociative seizures usually occur when there is an underlying psychological issue.
Okay.
So we found that a lot of the time there might be a history of trauma, not necessarily physical trauma. You could have a history of sexual abuse or bullying,
Okay.
and that could have been the trigger for the episode.
Okay.
And in these instances, it doesn't stem from abnormal electrical activity in the brain, but it's the body's way of coping.
Right.
So it's the body's way of protecting themselves.
Okay.
They're manifesting these abnormal movements because of what has occurred to them psychologically.
Okay.
So we still need to treat them. Some of them may need to see a psychologist or a psychiatrist to help with managing their symptoms. And if they have associated epileptic seizures in association, then they'll need anti-seizure medication as well. So it's still important to report so we can distinguish between the two.
Okay, reminds me, Prof. Eben Bedu, MOBA. I greet you. I remember a case we handled very, very, very complex and borderline, right? Where, like I'm saying, the mother was adamant. And this is a child I had to literally hold in, if it was UFC or wrestling, they'll say a rear naked neck choke, right? Just to, and I remember now Professor Henry saying, Nortey, you let him relax. I said, you haven't seen anything yet. So he starts doing his thing. Then, Nortey, are you holding him? I said, but I thought you said he should relax, right? Then he struggles with me, but right before our eyes, in the consulting room with his mom, Prof. Henry and me present, he exhibits a seizure, right? It started as if he was struggling with me, right? Or even trying to headbutt me backwards, but he had a seizure live, direct there, okay? And then we said to Prof. Bedu, this thing is back and forth. And he said, those people, please, I see them in the corridor, because he's kind of messed up his consulting room a bit. But these are the challenges we face in classification, and then we move on to treatment and management.
Yes.
Okay. If you have any questions, concerns, queries of my docs in the studio, WhatsApp is 055 11 11 997. I will activate the phone lines promptly since we started late. 030-221-6541. If you are a diligent, discerning student, then you know where we are at already. We're talking about childhood epilepsy. February 9th every year is International Epilepsy Day. There's also a World Epilepsy Day, but this is the International Epilepsy Day. So we, zeroed in on that with my docs in the studio. All right. If you have any questions, WhatsApp 055 11 11 997. And of course, the phone line is active 030-221-6541.
Joy 99.7 FM.
That's where you're at. Okay. Treatment. Last week, all the things about can people be cured, and we explained cure or remission, right, properly. But I'm sure it will come up again. But treatment. Okay. Having been classified as a child, right? And I'll need your clarification on that demarcation of who a child is, right? Having been classified and diagnosed as a child with epilepsy, what are the management treatment options available? Should I start with you, since you do the little ones, the kiddie booms and the kiddie bumps?
Yeah, so by definition, a child is someone who is 18 years and younger.
Okay.
So in our department, we see children right from the neonatal period, which is day 0 of life, to 18 years old, before we transition them to our adult colleagues.
Okay.
And thankfully for epilepsy, we have so many anti-seizure medication available. Last week, we spoke about the two main types of epilepsy, whether it's a generalized seizure or a focal seizure. That is important in determining what type of anti-seizure medication we start a patient on.
Okay.
And in children especially, you could have some specific epilepsy syndromes or specific seizures which respond more to certain anti-seizure medication. So one of the more common types of epilepsy we see in children are infantile spasms.
Okay.
And these are seizures that are usually seen in children around the age of 6 or 9 months old.
Okay.
These children usually have a history of certain things like birth asphyxia. So when they were born, they did not cry, which means oxygen didn't get to their brain, and it may have led to certain structural malformations, which led to them developing epilepsy.
Okay.
So these children with infantile spasms, sometimes you have a syndrome.
Right.
And a syndrome is when you have a constellation of symptoms. So you have certain things like the seizures, which in this instance will be the infantile spasms. They have developmental delay. So they don't achieve their developmental milestones at the appropriate ages.
Speech, walking,
everything.
Everything is delayed.
Is delayed.
On account of this brain pathology.
Yes.
Right? Something happened to the brain because you didn't breathe at
when
birth,
you were delivered. Yes.
Right? Before, you were breathing through your mother, right? Through your umbilical cord.
Yes.
And that is why the midwives, God bless my mother, they spank your bottom so that you cry.
Stimulate you. Yes.
Right? That cry is actually your first breath. If it is absent or delayed, then maybe brain pathology. Let me call it that. If I say damage now, we'll get in trouble. Right? So you're saying that on account of that, their development is also delayed in various ways.
Yes.
So they will miss certain milestones.
Yes.
Right? Okay.
And then they'll also have these seizures, which we call infantile spasms.
Okay.
And then the third part of the syndrome is usually diagnosed with the EEG.
Right.
So when we do EEGs for these
don't like
children,
calling the full name. I like my listeners to
electroencephalogram.
All right.
When you do an electroencephalogram, you would see some abnormal patterns, which are usually diagnostic of this syndrome. So when all three exist together, the infantile spasms, the changes on the electroencephalogram, and the developmental delay, then a child is known to have something called West syndrome. West syndrome. And for these type of seizures, or for these children, what we usually do is we treat them with steroids for a short period of time, and then we use another anti-seizure medication, which helps to control the seizures. because the more seizures they have, the worse their developmental outcome.
Okay. All right. You're hearing all this on Joy 99.7 FM. The program is Ultimate Health, your ultimate guide to healthy living. This and every Sunday, 2:05. We're on the dot. Well, we sometimes come late. Yeah. Right? But we're talking about childhood epilepsy, childhood manifestations of unprovoked electrical activity of the brain. And if you have any questions, concerns, experiences, history, share with us. WhatsApp 055 11 11 997. Phone line 030 221 6541. Those are the healthy buttons to push
Joy
to give my doctors a
99.7
shock.
FM.
Right? But, okay, so we've understood that. Okay? So we can identify some of these things, and we want to be able to have, should I say, some concurrent validation of what we're seeing. It's on the EEG, but we're also seeing this and that, and so on and so forth. There's a history of this and that and that and that.
Yes.
They come together, and conclusively now we can actually diagnose. Okay. We talked about the prevalence for children, but can you just hit on that again? In children, what's the prevalence of childhood epilepsy?
We said 1 in 26.
1 in 26 children.
Yes.
That's serious.
It is.
1 in 26 births.
I think epilepsy is the most common childhood neurologic condition we see.
1 in 26. Okay. What's it like in the Western world?
I'm not sure
You're
about
not
the
too sure.
numbers.
Okay.
Yes.
All right. Okay. So it's pretty common.
It is.
And therefore, if you've seen anything like what we're talking about or what we talked about last week, well, draw closer to a facility. At the general level, they are able to pick up some of these things, and then you may progress to seeing a specialist. All right, but don't say because you have to see a specialist, you're not going. Right. At the general level, my docs confirm that doctors are trained, equipped to pick this up. Yep, Dr. Dakwa.
Yes.
Okay, right. One is calm, one is the other one. I'm trying to ginger him today, but it's not working. Okay, right. So we've got that.
Yes.
Anything else we want to say about the classification before we move into treatment? She's mentioned some of the treatment already. Okay, and I'm hearing what sounds to be predominantly or primarily pharmacological treatment, drug treatment. Is that the case?
Yes. So something to add to that, when we give them medications, one of the things we tell the patients is that the effect of the medications will not start on day one.
Okay.
Usually it takes time for the medication to build in the system before the control is achieved.
Okay.
And even at certain times, we'll have to increase the doses to get to target.
Okay.
If people don't see the results immediately, this is one of the reasons why they can't stop treatments.
They will default in treatment because they expected shishishi.
Exactly.
So now what you're saying is that the target or the objective of treatment with drugs is to control the seizures.
Yes.
Control, to my mind, means we're reducing the frequency of seizures, and hopefully we can get them to drop out of the picture altogether.
Yes.
Okay. So parents are expecting that once they've come to you, you've thankfully, maybe unfortunately, but thankfully diagnosed, pinpointed this condition, then you start medication. But it may take some time before you start to see an impact on the frequency of seizures.
Yes.
Right. So your child may still be experiencing seizures.
Yes.
Okay. Right. Okay. Is there anything you want to add to that for your parents?
I think that's the most important thing. And then also to know that when we do start treatment and the seizures start to get controlled, it doesn't mean that you're stopping anti-seizure medication.
I like that. Okay? Because there's a lot of misinformation, intentional disinformation, right? And myths and stigma and discrimination. The urgency and the tendency to default and stop treatment, right, and run away from these nice docs. I don't know why you're going to run away from these guys, but it's high.
It is.
So you're saying once treatment has started, you stay with it.
You need to continue.
Any modification, alteration, adjustment of treatment is done by the doctors.
Yes.
Yes.
Not you. Not your pastor.
No.
Right. You say that very calmly because I take those
should
ones
shout.
seriously. Yeah. Not your pastor. Because I have people who travel. I went to this church and right. One of which is responsible for my delay. A church. Yeah. Yeah. Right. It's very important to hit on this.
Yes.
You've started treatment. We have said that it is largely and perhaps maybe even highly treatable.
It is, yes.
So you do not, must not, shall not stop treatment because you are seeing some control and a reduction in frequency of seizures.
Yes.
Okay? All right. I hit that hard because I know when people run away or they're hiding treatment or hiding even the diagnosis. Right? This is
Exactly.
important. Okay.
And let me just add that
Yeah.
it's important to also tell them not to be
Joy
taking other
99.7
medications
FM.
in addition to, because these can interfere with what you are giving to the patient.
Okay. You shouldn't be taking other medications alongside. If you are taking other medications, your doctors should know.
Should know.
Right?
Exactly.
Very often they don't tell you guys, but they tell us. Right? Is there a reason? They're afraid of you guys.
But we do all to ask them
Okay.
before starting,
Right.
including herbal medications,
Okay.
local preparations.
Okay. Phone lines are still active 030-221-6541. Ultimate Health on Joy 99.7 FM with me, Nortey by nature. We're talking childhood epilepsy, and you can call or you can WhatsApp 055 11 11 997.
Joy
Okay.
99.7 FM.
So we are not mentioning names of medication. Is that deliberate, or people need to know what the anticonvulsants are? Is my child on one? Maybe he is, but he doesn't have epilepsy. Of course, sometimes they are used in different modes.
Yeah.
Right. Do we need to mention some of the names of medication that your child may be put on if they are diagnosed with epilepsy?
Yes. You want to start?
Okay. All right. Like we mentioned, there are so many anti-seizure medication. And most commonly in our clinics would use medication like sodium valproate.
Okay.
That's one of the more common ones that would use. And we like it because it's a broad anti-seizure medication.
Okay.
So it has the tendency to control both the generalized and the focal seizures.
Okay.
But like you mentioned, medication can be used for various
We
purposes.
use sodium valproate in many
We
other
do.
conditions.
We
Yeah.
do, even as commonly as patients with migraines or headaches.
Yep.
They could be on sodium valproate. So the
Okay.
fact that a child is or an individual is on sodium valproate does not necessarily mean that they have epilepsy.
Okay. You see that based on your own tongue, you've consigned yourself to coming back because
my
migraine.
goodness.
As soon as they hear migraine, they say, "Not to bring them back." Right? We'll get there. We'll get there. Don't worry. She doesn't want to come back. Okay. All right. So sodium valproate. Yeah.
Yes.
What else?
This is a long name. Levetiracetam. Okay. It's commonly known as Keppra. That's one of the brand names.
Okay.
But that's also another anti-seizure medication that may be started for a child or an individual with
Okay.
epilepsy.
Right.
We also have medication like clonazepam, clobazam, ethosuximide,
Carbamazepine.
carbamazepine.
Okay. Right. And when you hear those names, they definitely sound like they'll stop certain things, including irregular electrical activity. Is there anything we can say simply to explain to my listeners their mode of action? How do they control or get into this electrical business in the brain?
Okay, so most of them work directly in the central nervous system.
Okay.
And their work is to reduce the threshold for these electrical activity bursts.
Okay.
So they have this CNS or central nervous system depression effect.
Okay.
And that leads me to one of the things that we tell our patients, that sometimes you might see some side effects from these medications. The individual can become a bit drowsy, they might be sleeping a lot because of that.
We've depressed the nervous
depressive
system activity.
effects.
Right.
Yes.
Okay. Okay. So they're just, chilling things for you so that all these giddy things are less likely to happen. Now, one of the things I come across in practice is that depending on where your client is coming from, there's a certain preference or non-preference or, discouraged use of some of these medications we mentioned. I come across some UK, we don't really use this and we don't like Keppra and Is that normal, that almost regionally or depending on where the child is being treated, there are certain medications that on their formulary they use for first line and so on and so forth. Because sometimes a parent has come or traveled from abroad with a child, and now they come here and they hear you recommending this, and they want to use what they were using in the US, Canada, or UK. Is that a normal, should I say, disparity?
I think that is one of the important things that limits our treatment of epilepsy in our part of the world. So there's a treatment gap.
Okay.
We know that someone has epilepsy. We know, for instance, if it's an absent seizure, we know the first line for that is ethosuximide.
Okay.
It's not readily available here as it is in other jurisdictions.
Okay.
And even when it's available, it's quite expensive.
Okay.
So one of those may be a limiting factor. The other thing is just generally availability of certain medication.
Okay.
We don't have access to all the medication that individuals in more advanced countries would have access to.
Okay.
And there are studies that are showing new things every day.
Right.
And for those reasons, we may shy away from using certain medication in certain groups of individuals.
Right.
For instance, adolescent females, sodium valproate may not be the first line because of the possible side effects when they get pregnant.
Okay. Right.
Just to add to it, I think you need to classify your patients, and there are a lot of factors involved. You need to find out the region where the patient is, what medications are available there, and then coming back to your patient who has been classified, then you know the best outcome or the best medication to give them.
All right. And this will all be explained to the patient and, in this case, parents, significant others.
Yes.
Okay. If you have any questions, 47 minutes past the hour of 2. We're running out of time. Yeah, but we're talking about childhood epilepsy, very, very common. And we're looking at this irregular, unprovoked electrical activity of the brain, which may lead to various manifestations and presentations, okay? Some of them you may not even see anything happening, right? And it's still a seizure. Right? It's still a form of epilepsy. We dealt with that last week. Some of them too, you see all the things you've heard about or not even seen but believe are part of epilepsy. All right? Last week we explained tonic-clonic, right? Shaking, rigidity, and many other things. Okay? We also explained why a person experiencing some of these more overtly visible seizures may also foam at the mouth. Dr. Dakwa explained that quite clearly last week. Okay, so if you have any other things we haven't explained, please 030-221-6541. Ultimate Health on Joy 99.7 FM.
Joy.
Before the comments come in, I wanted to mention something important. When the patients come to our clinics with these diagnoses, they don't have a seizure there and then. So one of the things we advise is for people or relations to, if possible, take a video of what's going on, because
when a seizure occurs,
film
it.
Yes.
Capture it.
Yes.
Right.
The description of the seizure event is very important. We need to know what was happening, where the patient was, and then how the seizure progressed and what happened after.
Okay.
So we need, and usually we keep this in confidence, so there's no way we are going to share it on social media.
Okay.
But it helps a lot if we have an idea of what's really happening.
All right.
Yes.
If your child has a seizure, they're not going to do you the honors of having it in the consulting room.
No.
Okay. So you may think they've withheld it. No, it hasn't happened. Right. So if it happens at home, privately, domestically, capture it, film it, and use that to also help to describe the seizure to the doctors when you go to hospital. That's important.
Yes.
Now, there was another important thing that comes across in practice, right? Can I have a seizure? Can a child have a seizure in their sleep? And what would that look like?
Joy.
Yes, it's possible for seizures to occur when a child is asleep or just falling asleep or just waking up from sleep.
Okay.
And it depends on the type of epilepsy that the child has. So some types of seizures may occur with the shaking, the stiffness of the arms and the legs. Some of them may be the drop attacks where they lose tone suddenly.
Yeah.
You could even have some seizures where all you hear is that they're making an abnormal noise.
Right.
And you may see one side of their face twitching, and they may be sleepwalking.
Okay.
And they don't remember any of that happening. So yes,
Okay.
it's very possible for
Right.
seizures to occur
Your
in
child
sleep.
can have seizures in their sleep.
Yes.
Okay. We talked about lots of muscle tone and muscle control,
Yes.
urinary incontinence, and sometimes fecal incontinence, which means I may soil myself or pee on myself, and so on and so
Exactly.
forth. Are there any other things that are notable or significant?
So the one that comes to mind is what you mentioned about the fact that people send their relations to a psychiatric facility.
Mm-hmm.
They may come with behavioral changes.
Right.
People can be confused, people can become agitated, aggressive,
Mm-hmm.
and you need to also take note of all these things as
Okay,
well.
right. We also mentioned the possibility of an aura or some kind of sign or awareness that precedes the seizure itself. Right. Being a child, so to speak, would I be aware of an aura and would I be able to explain it to my parents?
So that's
Okay.
interesting. Just this week, I was talking to a parent whose child has epilepsy.
Right.
And she'd mentioned that the seizures had been well controlled.
Okay.
And then just during this week, she had another episode.
Mm.
And this was one of the stiffening and shaking ones.
Okay.
And she'd asked her daughter whether she'd noticed anything before the seizure had occurred.
Mm-hmm.
And she said she could smell Gary. So I asked, is that something that always happens? And interestingly enough, she said yes. She usually says that she smells something shortly before a seizure happens.
Right.
It's usually food, so rice cooking, then she starts to feel something weird in her tummy, and then she'll have an
Excuse me,
episode.
is she Obolo?
She's not.
She's not. Okay.
She's not.
So she has an olfactory
Yes.
aura.
Yes. So she
Olfactory is to do with
smells.
smell.
Yes.
Okay.
And I've had a few children at the clinic, and when you ask them what happens before the seizure, they
Yeah.
would draw something. So they have visual aura.
Right.
They
Okay.
see something before the
Okay.
seizures occur.
Right. Okay. I have a call on the line. Hello. Good afternoon.
Please, I'm Eugenia.
Eugenia, just lower the volume of your radio or TV and continue, okay? You're welcome.
Okay. Please, I'm calling from Akachi.
You're calling from Akachi. Go ahead.
Yeah, I had a son who is 10 years now. He used to have such a thing here that you're calling of. But now it has stopped. But he has a problem of ADHD and then speech impairment. So what sort of help can you give to me?
Okay. So you're calling from Akachi, yes? Your son is around 10 now. You say the seizures have
Yes.
stopped.
Yeah.
Did they stop in response to treatment or they just went away by themselves?
Like I've not been giving him any medication.
Okay, because you're mentioning ADHD, speech deficit, obviously it sounds like you've been close to some professionals or facility. Am I right?
Yeah.
Okay, so where did you take your son?
Oh, first when the seizure was happening to him, we've been taking him to Akachi District Hospital, now Municipal Hospital. But they don't give. He was given sodium valproate, but we couldn't continue it. We stopped on the way.
Okay.
It was about 5 years when that started. But now he's no more on any medicine. The medicine, we couldn't even use it after 1 year.
Okay. All right. So let me just emphatically, you were non-compliant with the medication, but thankfully the seizures seems to be gone for now. All right.
Yeah.
And you're saying he has a speech deficit, and he also has attention
yeah.
deficit disorder with hyperactivity.
Yes.
And you're asking what to do.
Yes, yes.
Okay. So I'll let you listen to Dr. Hannah Sharon Mills.
Okay, thank you.
All right, so in this instance, the best thing to do would be to report back to the hospital. The fact that he has speech delay and then attention deficit hyperactivity disorder, we have treatment for that. So speech and language therapy can hopefully help with the speech delay. I don't know if he's had a hearing assessment done, because that would be important before any form of therapy is started. And for a diagnosis of ADHD, I don't know if that was made clinically in a healthcare setting, but there are certain criteria we usually look out for. And then if those are present, we can start therapy with the psychologist, we can do behavioral therapy, and there's certain medication we can start as well to help with the inattention and hyperactivity. So it's best to report back to the health facility.
Okay, you see, now you're now looking like somebody I've seen in class before. But yes, these are very important things, okay? When you start hearing speech delay and all of these things, most likely something has done something to the brain or brain activity which controls these areas, okay? Some rarely maybe without brain pathology, right? And these are the reasons why doctors will ask you about pregnancy, labor, did he cry at birth, how old was he or she when she crawled, We're looking at developmental milestones and if they've been missed or harmed or compromised in any way, okay? But importantly, Doc says, go back to Akachi, catch them. Catch the Akachi people, go back, yes, the seizures are not there, but there are residual, should I call them, signs, right, that need to be looked at. And if it is ADHD, have it properly diagnosed, and then you can look at proper intervention for that. Thank you so much for sharing that. Good afternoon, Nortey. Please ask for me, what are some of the things some pregnant women or expected mothers do that are dangers for the unborn baby? I knew this had to be a jingle from every time he's looking for something somebody did. So far as epilepsy is concerned, Ajiman Joseph, can a mother who is carrying a baby do something that will lead to, cause, or be related to epilepsy?
I don't know why we're asking about the mothers. What about the fathers?
This is a jingle. A jingle, you don't know. He will ask those ones first. Then he will, as soon as we finish that, he will ask, is there anything we eat that causes it? But let's deal with this one before he gets more.
Okay.
We're almost out of time. Yeah.
We mentioned that with epilepsy, there are certain things that can happen during the delivery process. But just for any other pregnancy, it's important that any woman who is pregnant attends antenatal care.
Okay.
Because if you have certain risk factors like hypertension in pregnancy, diabetes in pregnancy, it could increase your chances of having a difficult delivery, which could result in birth asphyxia. And so all women who are pregnant should take their routine antenatal medication and go for regular antenatal care. If a woman takes certain unprescribed things during the pregnancy, alcohol being the most common, or smokes cigarettes, or uses illegal drugs, then there could be a possibility that there could be changes in the fetal brain, which could result in epilepsy later on in life.
Okay.
Just to add on, I think antenatal attendance is very necessary.
Critical.
And if you attend your antenatal checkups.
You say it so nice. Very necessary. Charlie, my people, some of them are TVO.
Yeah. So when it's about 13 weeks, you need to find an antenatal clinic and attend.
You must attend antenatal.
Yes.
Right? Go to antenatal and especially postnatal too, because the numbers change drastically after they've given birth and they've won the white.
Yes.
Right? So please hit that hard. Right?
Yes.
Antenatal is monitoring you, the mother, and your pregnancy.
Yes.
It's critical. Non-negotiable. Go.
And some of these things can be picked up early and sorted out before it gets too advanced.
Okay.
Yes.
All right. Okay. Some of you think we are comparing the women who's looking nice with their pregnancy, who's looking too long. And No. We need to monitor that pregnancy. Right? It's like an airplane that has taken off. It must arrive at its destination. Okay. So go. Ask your questions. Tell them what you've been taking in accordance with folklore, what an auntie said, and so on and so on. Some of them may be problematic. Okay.
Yes.
So go for antenatal. That's what my doctors have said. Anything you want to leave my listeners with childhood epilepsy? Is there anything that we haven't touched on? You talked about some of the possible side effects of some of these medications, drowsiness, and so on and so forth. We've talked about the seizure itself. Anything? Hannah Sharon, I've gotten your name right. You can't dodge. You do migraine pair. Anything you want to leave my listeners with?
I think the most important thing is that we shouldn't hide the fact that a person has epilepsy.
Okay.
When we hide the diagnosis, it's part of the stigma. It delays making a diagnosis, it delays treatment, and it delays having a good outcome.
Okay.
So as much as possible, don't hide the fact that you have epilepsy. It's treatable.
Okay. And please, Osofos, yes, some of you say things, and there are some references, some claim are biblical, that's, they use to spin off certain stigma and discrimination. Okay? Look, a condition is a condition. A disorder is a disorder. A disease is a disease. All right? If somebody has it, we reach out, and thankfully, we have trained professionals in different disciplines that can help this child.
Yes.
Okay? So if you're preaching in church, or if you feel the church has shunned you because of your child, something, no. That is wrong. Go to a hospital and get the needed help. Many thanks once again, Dr. David Dakwa and Dr. Hannah Sharon Mills, who will be coming back to do migraine. Right, I hope we've tidied up on this. This is Hi Nortey. Thanks for the insightful discussion. I'm almost 50 years now. As a child, I had seizures which stopped at a point without any serious attempt to treat it. At my age now, I experience frequent migraine and was put on carbamazepine, Tegretol. What can I do about it, please? I would also like to know lack of breath included, or were you trying to say induced CS? I see a CS there. Okay, I have to come back to you off air, okay? But thank you for sharing that. We'll get back to you. I have your number on my screen. Many thanks to Ziggy, my producer. Apologies for coming late. Hey. They say weapons from there. Some of them, they prosper small, but I made it. I'm so grateful. That is why I say everybody has a miracle with their name on it, all right? So I'm going out with that. Hey, Moses Bliss. Hey, my mouse has frozen. Where is it? There it is. Okay, Moses Bliss. Take it.